Welcome to the Endocrine for Infants and Children with our most famous Dr. Jennifer Miller. All right, my name is Christy Rickenbach. I am the Parent Support Coordinator at PWS USA, and I'm also the proud mom of Justice Faith, who is 21 living with PWS. Dr. Jennifer Miller is a professor of pediatric endocrinology at the University of Florida. And I'm going to read this whole thing, so everybody listen up. And one of the world's leading experts in Prader-Willi syndrome. She You're making this hard. She earned her MD from the University of Florida in 1998 and went on to complete a master's in clinical investigation in 2005. You want to keep going? Okay, Dr. Miller serves as the principal investigator on multiple clinical trials, advancing treatment options for individuals with PWS and hypothalamic obesity. She currently follows several hundred, perhaps thousands, individuals with PWS from across the United States and around the world, bringing both scientific rigor and deep compassion to her work. We're honored to welcome Dr. Miller to share her insights and expertise with us. Please give a round of applause for Dr. Jennifer Miller.
Bad day. How does this work, Christy? Yeah. You're just gonna let me know? You're gonna let me go? Where do I point it? Like that? Okay. I just need you to know that I did not write all that nice stuff that Christy just said about myself, because, yeah. I wrote some words, but there were very few of them in what she just read. I think 1998 was part of it, but, that's about it. I just want to thank you for coming to listen to me instead of caring for the caregiver. And what were you going to go to, Amy? Finding my Zen? I shall help you find your Zen. I shall try to be in a better mood. Okay, these are my disclosures. I've gotten research funding from all those places. Okay, so we are going to, here's a clock. We're going to try to get through all of this stuff. One of my main agendas today, however, has become a personal mission for me, which is to be able to answer your questions about VYCAT XR in front of other families if you have questions that you think you want to learn about. So I will be happy if we are able to get through all this. If we are not, and we're getting close to the end, I'm going to probably stop and just ask people if they want to ask any questions about the medication, monitoring side effects, all that kind of jazz, because I do think that y'all need to understand it, need to know what to do so you can tell your doctors what to do, which is always fun, I know. Okay. Growth hormone in infancy. So the average age of diagnosis of Prader-Willi is now 1.2 months of age. That baby lives in Virginia, but he was a gator before he ever came to the University of Florida. Growth hormone therapy has been shown to improve cognitive function, especially when started before a year of age. So it doesn't have to be 2 months of age. It doesn't have to be 2 weeks of age. When started before a year of age, growth hormone improves cognitive function. It increases blood sugar levels, which is one of the ways that it's thought to improve cognitive function, by stabilizing blood sugar so you don't have a bunch of hypoglycemia going on during infancy. It improves body composition, as you probably all know, by decreasing fat mass, increasing lean muscle mass. And we also know that growth hormone treatment in infancy shortens the time of nutritional phase 1A, which is the time needed for assisted feeding, so the NG tube or the G tube. And so it shortens that time that you need extra assistance with feeding. I love this. Okay, sleep studies. This is a big issue for a lot of the parents with young babies. Those of you who have older children know how I feel about this issue. But if you have a baby, and you haven't heard me preach on this, growth hormone, many years ago in 2008, I wrote an article that said that we should do sleep studies before and about 12 weeks after starting growth hormone to make sure that growth hormone didn't improve or didn't exacerbate the risk of sleep apnea and potentially cause death. We've subsequently learned that that is not a thing. And so I've not been recommending it for babies under the age of 6 months. And here's why, for you to take back to your doctors. Babies don't have tonsils and adenoids. You get adenoid tissue at 7 to 9 months of age. You get tonsil tissue at 15 to 16 months of age. If your kid is 3 months of age and you're wanting to start growth hormone, there's really nothing on a sleep study that would stop me from starting growth hormone. If you have obstructive sleep apnea on that initial sleep study, it's because you're low tone. And growth hormone is going to improve your muscle tone, and that's going to fix the problem. If you have central sleep apnea on that first sleep study, it's because your brain is immature. Growth hormone is going to improve that and improve your response to carbon dioxide levels. So there's nothing about that initial sleep study that should change the plan of action, in my professional opinion. And so like I said, I no longer recommend doing sleep studies routinely in young infants before starting growth hormone. 6 months is my cutoff because adenoids, like I said, can start at 7 months of age. So above 6 months of age, when you're getting started on growth hormone, I do a sleep study just to be safe. Where'd it go? Oh, that was cool. All right, I just said all that. All right, so there you go. That's it. That's what I just said, all of that on one slide that I hadn't realized I had made into 3 slides. So anyway, so yeah. So the other thing is the FDA just approved the Owlet, which is the monitor, that a lot of people use to watch for desaturations and bradycardias and such. And so if you're feeling uncomfortable without a sleep study, you can do that, which a lot of people do anyway. All right, so y'all people in the back there, the Cooper family, were asking about, yeah, you got named, haha. We're asking about adrenal issues before starting growth hormone. And so the thing is that growth hormone, because it increases metabolism, it can unmask other pituitary hormone dysfunctions. So with Prader-Willi, you can have dysfunctions of one or many pituitary hormones due to the fact that the hypothalamus and pituitary don't form quite normally in utero. And so because when you increase the metabolism by starting growth hormone, all of a sudden your pituitary gland may be able to put out some thyroid stimulating hormone, but now that the metabolism is higher, maybe not enough thyroid stimulating hormone. And so often it will unmask what we call central hypothyroidism. So you have a pretty normal level of the hormone that most people check for thyroid, which is TSH, but with this condition, you can't just check that. You actually have to check the thyroid hormone circulating in the blood, because that's what will be low if it's going to be low, and that's called free T4. The same thing becomes true with the adrenal. So you can have totally normal cortisol levels before starting growth hormone therapy, and because your metabolism goes up with growth hormone, you might need some extra cortisol during your life, during times of illness or something like that. I'm just saying that just because something is not there before you start the growth hormone doesn't mean it's not there for the rest of your life. You have to be aware that these things can be unmasked as our children grow and change, and growth hormone doses grow and change with them, and their metabolism changes. So again, when you're getting labs done for your child, I advocate for thyroid hormone testing every 6 months, and all doctors like to do a TSH, which is fine, it's going to be normal, but it's a free T4. That's what you want. That's the thyroid hormone circulating in the blood. So hypogonadism is pretty characteristic of people with Prader-Willi syndrome. It's listed about 80% of individuals with Prader-Willi will have hypogonadism, and that means that either the testes or the ovaries are not functioning normally. And so in baby boys, we use a hormone called HCG, which is the hormone of pregnancy. And that hormone will often allow the testes to descend on their own without requiring surgery. It may not do that, though, depending on where the testes are living right at the moment that we're doing this. So we want to recapitulate what we call the normal mini puberty of infancy, which happens between 0 and 6 months of age in male babies. And so by giving the HCG kicks the testicles into action and has them produce their own testosterone. So we could do this with testosterone and just give testosterone, but then the testes don't have to do anything. Did you see me hit that microphone? And so I like the idea of giving the child the opportunity for their testicles to work normally, to produce testosterone on their own. And so that's good enough for me. But the other thing about this is a lot of urologists will say, no, it doesn't bring them down in everybody. And that's true, it doesn't. But what it does do, if any of you have baby boys, you know this, if the testes are undescended, the scrotal sac is really small. And it's gonna stay really small, even if you bring those testes down surgically when they're 1 or 2 years old, because it's underdeveloped. What HCG does is it actually improves the size of that scrotal sac so that there is room in that sac for those testicles to sit when they are brought down surgically, if they have to be brought down surgically. So is it a fix for this? No, it's not. It's not for everybody. But does it help? It does. And so I spend a lot of my life trying to convince urologists that just because the testes are up in the abdomen doesn't mean we shouldn't do this. You know, I know there's a kid's gonna have to have surgery, but I want everything to look and be as normal as possible, and I want it to be as natural as possible. So I like the idea of it coming from the testicles themselves versus us giving exogenous testosterone. Adrenal issues, which I just kind of mentioned, the hormone cortisol helps keep your blood sugar normal, your blood pressure normal, and helps your immune response. And so there's 2 ways you can have central adrenal insufficiency. So this came to be many years ago, that the Dutch group published that there was about a 60% prevalence of central adrenal insufficiency in Prader-Willi syndrome when they did a specific stim test. Then other groups published that there was a 0% incidence of central adrenal insufficiency when they did their stim test. And so it was kind of all over the map. Everybody had different answers, and this is the problem with central adrenal insufficiency, is that, you know, if you happen to have a low cortisol in the morning, which is what often people start with, and then you have to do this stimulation test, you can get false positives or false negatives, as evidenced by the fact that in the literature, there's probably 30 papers that run the gamut from 0% incidence of central adrenal insufficiency to 60% incidence of central adrenal insufficiency. My point being, I don't necessarily think that it's super important to check because you might get a wrong answer. When do I want you to check? I would love you to check when your kid's under stress, you know, if they're sick and you have to go to the ER, if they're about to get surgery done, or, you know, if they're in a car accident, God forbid, or something like that, you know, and have to get blood drawn. Do you have to? No. So I used to lean away from this, and now as I've grown up, I've leaned more towards this, is giving people just stress dose steroids in these situations, because we don't know the answer as to how many people actually have central adrenal insufficiency, and because just because you passed one test doesn't mean that you're safe. It could have been a false positive, you know. So now I just recommend, and all of you who are my patients know this, giving steroids prior to a surgery to make sure that the child is kept safe, or giving steroids when your child is in the ICU and intubated, you know, because of RSV, you know, to keep the child safe. Is there a risk to it? There's not. There's more of a risk to not treating with steroids than there is to treating with steroids when we're talking short-term use here. We're talking, you know, while you're in the ICU or while you're under anesthesia. And so that's sort of where I've fallen on this issue, because the data is just not the greatest. I don't think the bells are here, are they? Because it's my favorite picture in the whole world. Grace Bell hates my guts. Every visit, you see the happy on Grace Bell's face. So that was it for, so like I said, I'm gonna fly through some of this. I'm happy for y'all to ask questions afterwards if you want. But that's the main issues you need to know about for infancy, okay? I'm not talking about feeding, because you should have gone and listened to Michael Tan if you wanted to know about feeding, but I'm going to talk everything else. Mine's endocrine, which is why we should present together next year, Christy. Anyway, growth hormone deficiency is part of Prader-Willi, as we said, and so the recommendation is to start growth hormone as soon as possible after diagnosis. And so typically we like to start before age 1, and if at all possible. Of course, if you have a later diagnosis, you're not going to start growth hormone until later, and that's fine too. The data from the Dutch group shows that growth hormone at any age actually improves IQ. And so, don't feel like you're way behind the 8 ball if your kid didn't get diagnosed until they were 3 years of age. It's not your fault, it happened. And so, still it's going to make a positive difference in the life of your child. The other things I mentioned in the infant talk now come to being here in toddlerhood. So central hypothyroidism, the average age of diagnosis is around 18 to 24 months of age. Now, this is also the average age of nutritional phase 2A starting, which is when the child gains weight without a change in calories. And so sometimes doctors will say, oh, your kid's gaining weight. It's just Prader-Willi. Please check the thyroid. That's what you want to say. Please check the thyroid. 20% in that age range, okay? Hypogonadism still is around at 50%. Now, here's the kicker, because Prader-Willi does like to be weird, is that premature adrenarche, early pubic hair growth, super common in young children with Prader-Willi. Everyone says, oh, it's the growth hormone. It's not the growth hormone, okay? This existed pre-growth hormone. It exists on growth hormone. It's been there always. The adrenal gland gets activated. We don't know why. We don't know what is the trigger to activate the adrenal gland to produce androgens, or the male hormones that cause the body odor, the pubic hair, and sometimes even acne in young children. This does have to be worked up if it happens under the age of 6. Your endocrinologist will do it in a heartbeat. That's not even something you have to fight for. But just so you know, it is very, very common in toddlers to have premature hair growth. Premature adrenarche is what it's called. It's called benign premature adrenarche because it is benign. There's not a pathologic cause of it, and it doesn't end up altering your predicted adult height or anything else. It's just a little strange for families when their 4-year-old has some pubic hair and they're like, this is not right, but again, it's common. And it's not the growth hormone. Okay. A lot of times, if people are not my patients, they like to ask, what do I do after infancy in terms of monitoring? So I monitor labs every 3 to 6 months prior to age 3. I monitor IGF-1 and IGF-BP3 and a free T4 and or a total T4. After 3, I switch labs to every 6 months. And then you can see the labs. I'm not going to read them all there. And then if you have premature adrenarche, we get the following labs down there, the DHEA. We get other adrenal androgen labs. We get FSH and LH to make sure that there's not true central puberty going on, because we would like to stop that if that's happening. And we get an estradiol or testosterone level. Bone age. Bone age is somewhat controversial in terms of, well, people are like, okay, well, the kid has premature adrenarche. Doesn't that advance the bone age? And then people get really upset about it because they say, oh my gosh, you're going to be shorter because your bone age is older than you are. It doesn't really matter. Ultimately, at the end of the day, this does not compromise the final adult height. So to me, when people want a bone age, you can have a bone age, it's fine. I personally just don't see a reason to do it, because at the end of the day, it's not going to change anything about my course of action or treatment. So that's why I don't generally recommend doing it. Okay, so like I said, Prader-Willi likes to make things difficult. Any of you who have been through early childhood with a child with Prader-Willi know this. IGF-1 and IGF-BP3, its binding protein, both go up about a year after being on growth hormone therapy when you have Prader-Willi. Very unique to Prader-Willi. And they go high. So you could be on the same dose, and at 15 months of age, your IGF-1 and IGF-BP3 are stone cold normal. Nothing changes. You go back at 24 months of age, and now they're super high, like 3 or 4 standard deviations above the normal range. And people freak out. Doctors. Parents don't usually freak out. Doctors freak out. And so this has been a subject of discussion in the endocrine world for many, many years. And there was a point in our lives where we said, well, why are we even checking? We know that this happens, and it doesn't seem to mean anything if there's no signs of overgrowth. We're not growing the child too rapidly, and the child's not, maturing too quickly. Then why do we need to follow this when we know it's abnormal, and it's going to be abnormal starting about a year after you start the growth hormone therapy? And The answer is because endocrinologists like numbers. That was the answer that we decided on. And so, to solve the problem, the Anita Hoken's group in the Netherlands did a very lovely study where they figured out how to calculate a molar, think back to chemistry, a molar IGF-1 to IGF-BP3 ratio. So IGF-1 is the active hormone that actually causes growth, okay? IGF-BP3 is its binding protein, and they circulate together in the blood. And so by calculating the ratio of these two together, it will give you what we call a free IGF-1. The free IGF-1 is the stuff that really matters. That's what is actually being produced once growth hormone binds to its receptors, and that's going to be your active IGF-1. And so if you want to see, is my dose of growth hormone too high or not, you don't look at the numbers that you get on that piece of paper that's an IGF-1 and IGF-BP3. You actually calculate this ratio, and there are norms for age and gender that go along with this calculation that have been published by that group. We don't know the tissue bioavailability or the safety and efficacy of the growth hormone dose just from looking at that IGF-1 or IGF-BP3. So that's why we look at that ratio together. And it is critical that you understand that there are differences between that IGF-1, which is, again, the number you get on that piece of paper, and that molar ratio. The molar ratio, once that IGF-1 pops up, this is what you use for a very long time until it no longer is high. But actually, I use this forever after that. So I started in infancy, actually. And like I said, the next slide is going to show you a table that's got normals for age and gender, so you can take a picture if you want. This ratio actually makes it possible to optimize the growth hormone dosing so that you are going to minimize your risk. So everyone's worried, high IGF-1, is it going to cause cancer? You know, and the answer is, if it's not biologically active IGF-1 that's floating around, is it a risk? It's probably not. It's that free IGF-1 that's the metabolically active IGF-1 that's the stuff that we really care about. That's the stuff that's the number you get from calculating that molar ratio, okay? So it allows you to minimize risk with growth hormone therapy by knowing what your actual free IGF-1 level is to make sure that's not too high, while maximizing benefit. Because one of the things in that study that they showed was when the doctors reduced growth hormone simply to account for this high level, kids started to lose some of the benefits of the growth hormone therapy. They started to get a little bit more body fat. They started to, not have as much stamina. Their metabolism slowed a little bit. So you really don't want to adjust downward the dose of growth hormone based on that one number or both numbers being high. You want to look at the ratio. And that's how this is the ratio. So you look at all the numbers and calculus and chemistry. Fun times. Just take pictures, because I'm not even gonna say that out loud. I have it literally scotch taped to my computer in my office because so what they found was that when they did this molar ratio calculation, that free IGF-1 was exactly the same as what that total IGF-1 had been before the whole thing, So the free IGF-1 is really your measure of your growth hormone dose. Why does this happen? We think it's actually insulin. We think that insulin plays a big role here. So high insulin levels happen in Prader-Willi starting really basically in infancy, that children with Prader-Willi make a ton of insulin response when they're eating. And that insulin has a 60% crossover reaction with IGF-1. So if you have eaten or drank anything that has any kind of carbohydrates in it before you go get your blood level done, your IGF-1 is going to be high. How hard is it to get blood from a 15-month-old with Prader-Willi who's eaten or drank nothing? It's freaking impossible. So you have to do this. Well, except for Samara. We will give her the credit of, if you want to come to Samara, she'll draw your kid. But anyway, so most people feed their kids before they go in for these levels because they know how hard it is to get blood and they don't want their kid to be poked 1,000 times. So So anyway, so this is it, and this is likely why the IGF-1 levels go up. It's not actually related to growth hormone at all. It's related to nutrition. So IGF-1 and IGF-BP3 are driven both by growth hormone and by nutrition. And when your insulin levels are high, that indicates to your body that you're overnutritioned, okay? In this case, it's physiologic with Prader-Willi syndrome, but that is why we think that happens. Okay, so puberty hormone replacement, I only have 33 minutes and I want to make sure you guys have time to get your questions answered. Puberty often begins normally, sometimes will then fail on its own. We've seen more and more kids actually go through puberty more completely on their own as time has gone on. At this point, I'm quoting a rate to parents of close to 50% of the girls and probably 30% of the boys are actually going through puberty completely on their own without us having to intervene with estrogen or testosterone. Why? I don't know. I suspect early growth hormone plays a role in that. I also suspect weight plays a role in that. If you're overweight, puberty is abnormal, just even in the general population. Prader-Willi takes everything that's normal and amplifies it. So I suspect that this is the reason why, as kids now, we know the right diet to use. Kids are more active. They're diagnosed really early. They're on growth hormone. I think it all plays a role, but I do think weight plays a piece of this for sure. And so the general recommendations that I was a co-author on are to replace estrogen and or testosterone to help complete puberty for the purposes of bone mineral density. We use a protocol that we use in Turner syndrome, which is a syndrome that we have to use estrogen replacement for. We use that same protocol for girls with Prader-Willi syndrome, and every endocrinologist knows that protocol. And for testosterone, I actually use sub-Q testosterone cypionate. So it used to be that we always would either give testosterone as a gel, a patch, or an intramuscular shot. Someone at the scientific day said that didn't cause behavioral problems, and that's great that it doesn't, but I did see some behavioral problems in some of the boys. So when I started doing it this way, which I learned from some of my colleagues, they do this in the transgender world to give testosterone in a sort of slow and low fashion, and you give it once a week subcutaneously, so just like growth hormone, but only once a week. It worked beautifully. We saw a lot fewer behavioral problems, actually almost no behavioral problems using this, because you weren't getting those peaks and troughs of testosterone like you would if you gave a big slam of testosterone in the muscle and you had this huge rise and then a drop by the end of the month, because that lasts for a month. So anyway, that's how I do it. There are, and this has started to become more of a thing in the Prader-Willi world, so I just want to mention it to you. And it's primarily because our Prader-Willi patients for research trials are coming in with patients with other conditions that are there for research trials with me, and they're hearing about sub-Q HCG. So the same HCG that we gave in infancy, there are now protocols to do subcutaneous HCG twice a week for adolescent boys, which allows their testes to kick into gear and make the testosterone on their own with the HCG. So it's considered a more mild way to induce puberty. And the one thing that it does that testosterone does not do is it does allow the testes to grow in size. Wherever your testicle size is when you start giving testosterone in puberty to boys, that's where it is. They may even shrink a little bit. But if you use HCG, then the balls look like balls. And so they're, and people are happier with that. Your kid, his life, you do what you want. I'm just telling you they exist. But this discussion did come up in a research center visit with some of our Prader-Willi patients, hearing some of the other brain tumor patients talk about using this, and they were like, "Oh, I want to do that." It keeps everything looking normal. It's all good. There are protocols, and so I think it's important to know that hormone replacement, in my personal opinion, has to go on for life. You don't have to stay on the same dose of growth hormone as you get older, as you were on when you were a kid. You go down to adult dosing because you're no longer growing anymore. But I do think there's benefit to having growth hormone around at all ages of life. We all need some growth hormone. And so it helps body composition, it helps bone strength, it helps cognition probably still, stamina, strength, muscle tone. So I keep it on for life if I can. Interestingly, in adults with Prader-Willi, someone reported a few years ago that they have low levels of a hormone called T3, which is the active thyroid hormone at the level of your end organs. I had never actually checked it before, so I started checking, and I'll be damned, that person was right, that T3 is low in a fair proportion of people, adults with Prader-Willi syndrome. And so replacing it did help with daytime alertness and energy and that kind of stuff. So we check it in the adults and we replace it if we need to. There is in the adult patients a high prevalence of type 2 diabetes, high cholesterol, hypertension, and so really people have been talking at this conference all along about how the adults just disappear and don't have monitoring anymore. The adults need monitoring because these things happen. And so you have to have a doctor. If your kid is an adult with Prader-Willi, they have to have a doctor that is willing to monitor for these things and treat them as such. Okay. I am going to skip through this a little bit because like I said, I just talked about all that and diabetes. I'm going to talk real quick about diabetes just for a second, and that is to say that the prevalence of type 1 diabetes, which is an autoimmune phenomenon, is the same in Prader-Willi as it is in the general population. So for sure, we have patients that have Prader-Willi syndrome and type 1 diabetes. However, the great majority of diabetes seen in Prader-Willi syndrome is type 2 diabetes. So the diabetes that you get from typically, if you think about it, weight and insulin resistance. That happens with Prader-Willi as kids get older. It just does. It's just more common in Prader-Willi, and it tends the age, or as the age goes up, the prevalence of type 2 diabetes goes up. The average age of diagnosis, we looked at this in our patient population of like 300 people, and the average age of diagnosis of diabetes was 17.3 years. So that's way, way lower than the general population. The general population is 2/3 older than that when they get type 2 diabetes. So our kids are at risk for getting diabetes very young. And we think that part of that risk is actually that dysfunction of insulin release and regulation that has occurred since infancy. Like the pancreas gets tired. And so we think that that's a big part of why their risk of diabetes is at a younger age. Most people with Prader-Willi who have diabetes are pretty asymptomatic, actually. And so about 40% of the cases are actually found just incidentally on labs. And so it's really important to then make sure your kid has labs as an adult to check the cholesterol, but also the hemoglobin A1C and blood sugars. Okay, hyperphagia. I love that I put a definition up there for this group of people. Go me. But nutritional phase 2B is the nutritional phase where kids start to be more interested and aware of food. It typically occurs sometime around the age 4 or 5, 6 years of age. The kids start to ask a lot of food-related questions, have some increased anxiety, that's kind of generalized anxiety, start to get a little bit more rigid in terms of needing a schedule and a routine, if food's left out, a lot of kids in this nutritional phase will, if no one's around, they'll grab it. If people are around, they absolutely will not, and they'll say, look how good I am. I asked for it. But when you're not there, they'll grab it. I see people nodding. And so I do want to make this point very clear. We don't want your kids to be starving. Mike and I very, very much strive to make sure that kids that see us are at a healthy weight. If your kid doesn't have enough nutrition, they're gonna be hungry. That is not hyperphagia. And I can tell you, if you look at the older people, there's not many that have older people in this, older kids, but they'll all tell you the story of the time Dr. Miller told them that they were starving their child. And so, you do just need to understand that true hunger is gonna drive behaviors that look like hyperphagia. So the first thing we're gonna ask you, if your kid is 3 years old or 4 years old and you email Mike and I and you say, our kid's in hyperphagia, they're taking food out of the garbage, we're gonna say, what's their weight and height? And 9 times out of 10, the kid has lost weight and continued to grow. And so they're just really, really underfed. And so we have to say, first, let's try adding some calories. So it's important that you follow a well-balanced diet, not a ketogenic diet or a carb-free diet or, just the well-balanced Mediterranean diet. should help keep your kid well-fed, good muscle mass, and you should be fine. So this was done by Fred Quay and Dr. Jan Driscoll's lab, and this is his idea of how the individuals with Prader-Willi progress through these various nutritional phases to go into hyperphagia, which is anyway. So this is his cartoon of how this happens. Now, you all, I know, Blueberry Gate 2025, I'm well aware of what's happening on Facebook right now. And so I'm not on Facebook, but so why do Mike and I say what we say, right? I know that this has been a big issue for people going back and forth with each other about, well, they said 5 blueberries for my kid and they said 2 blueberries for my kid, and why do we do it? It's this, okay? Sweet taste causes, it's called a first phase insulin response. So the minute sweet taste hits your tongue, there is connection to the hypothalamus, which triggers the pancreas to release insulin, okay? But that whole system doesn't know nor care what that sweet taste is from. It could be from Diet Coke. It could be from chewing gum. It could be from flavored yogurt, okay? Or it could be from sugar. And so we know this to be true. We did the studies. I promise you, there's a whole discussion of whether there was literature to support this. I promise you we didn't just make this up. We did the studies and showed that indeed sweet taste drives up the desire to eat, okay? Because sweet taste, again, the minute it hits your tongue, your insulin starts to release. If you think about it, you have a Diet Coke, what's that insulin gonna act on? There's nothing there for it to act on, right? It's not a real sugar, it's not calories, it's nothing. Your blood sugar is gonna drop. And what happens when you have a low blood sugar? Who's ever had a low blood sugar? It makes you feel like crap. You're hungry, okay? You're shaky, you're hungry, you can't sleep, you can't concentrate, it's really awful. So this is why we say no sweet taste on a regular basis. Right there, that's why. And hold on, go to the next one. And that's because every spot along this line of progression to hyperphagia is exacerbated by sweet taste, okay? So that's why we say it. We wanna make sure, now I'm not saying that if you avoid sweet taste altogether, your kid's not gonna have hyperphagia, that's not true. But again, it's exacerbated by sweet taste. So you're gonna speed up the cycle with sweet taste versus things just going how they would normally go, okay? Okay, talk about everybody's favorite subject, VCAT, XR. I see you over there. All right, so the company's not allowed to tell you the stuff that I'm gonna tell you, but I'm gonna tell you anyway because they don't control me. And so the mechanism of action of VCAT is that first and foremost, it reduces that insulin release from the beta cells of the pancreas, okay? So I told you it's present from birth. It's hugely high, and one of the things that DCCR does is it reduces that insulin response from the pancreas in response to food. Now, when you eat, if you have Prader-Willi syndrome and you eat a regular meal, you eat whatever you just had for lunch, a wrap, with salad or whatever, you or I, our insulin might be here. Theirs is gonna be here, okay? Now you put a cookie with that or some juice to drink and it's through the ceiling. Okay? VCAT can't touch that insulin response that happens with the sweet taste. It's peeing in the ocean, okay? So that's why we say, people get so mad when Mike and I say the diet's even more important on the drug, and that's why we want maximum efficacy of the drug. Because look at all this other stuff that this drug does. Again, that they're not allowed to talk about, but I am, okay? It reduces fat mass, it increases lean muscle mass, and I'll tell you what, you guys, the best effects, it reduces anxiety, it reduces compulsive behaviors, it reduces the skin picking, all the stuff that we have always sort of said that's part of Prader-Willi, doesn't seem to be food related, it gets gotten with this drug. So why wouldn't you try to make the most of this medicine and get the best efficacy that you can from this medicine? Am I saying the drug won't work if you don't do this? No, that's not what I'm saying at all. I'm saying the drug will work better if you avoid sweet taste on a regular basis. Michael Chan, did we ever say no sweet taste ever? Never! You may have sweet taste up to 5 times per year for special occasions. We never said never. So we stand by what we said. We have not changed what we've said because of this drug. We've simply tried to explain to parents that if you want the best action from this drug, the best way to do it is to maintain the diet that we have always recommended, okay? Because it makes a difference and it makes the drug more efficacious. Look at these hyperphagia scores on this drug. I mean, compared to the natural history over 6 months and a year, you can see that the hyperphagia scores were statistically significantly different, better, lower, on this drug versus the natural history. 9 points, y'all, 9 points down, which if you think about, most of you have probably never done the hyperphagia questionnaire, but if you ever have, if you just dropped it by 1 point that like, okay, my kid didn't steal food 4 times this week, she only stole food 3 times this week, that makes a difference in your quality of life, believe it or not. When you're able to unlock your cabinets and your refrigerators, because your kid has stopped food stealing, then don't do it right away. Don't do it right away. It takes a long, 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 long time for the drug to kick in, I'm just saying. But it really does make a huge difference in quality of life. And like I said, here's the other piece that me, as a parent to all of your children, because they're all my kids too, look at what it does. Look at aggressive behavior, anxiety, rigidity and irritability, compulsivity. I mean, crap, that's like everything. Doesn't fix it. You're not completely typical, it helps. It helps a lot. And by changing those behaviors, can you imagine, those of you who have kids in this age range of, say, 6 to 15, the quality of life change that you would have if your kid wasn't asking you the same damn question 100,000 times a day? I mean, it's, right? I live it too with y'all. I just don't go home with it. Anyway, the adverse event profile was, as endocrinologists, it's exactly what we expected it to be for the mechanism of action of the drug. Increased hair growth on the body. Again, Facebook. Let me be very clear. Your child does not become a monkey. Your child doesn't get hair all over their body, head to toe, whatever else is out there, a beard, I can't remember exactly what else was out there. Doesn't happen. You know how with growth hormone, you get increased body hair, you get it on the arms, the legs, the back, your kids, everybody says, my kid's so hairy. I'm like, yeah, it's growth hormone. This increases the hair in those same areas. It does seem to wane over time. During the 6.5 years of the study, we didn't see it nearly as much by the end as we were at the beginning, but it's mild. It's not like, again, your kid's not gonna get a beard, I promise. Promise. Edema or swelling of the lower legs was more common in adults than in kids. And so that's something you do need to watch for and talk to your doctor about if it happens. And then high blood sugars. High blood sugars are a major concern as endocrinologists for people on this drug. The drug reduces insulin response release from the pancreas. When you reduce insulin release from the pancreas, its job is to put the sugar into the cells to be used for energy. And so when you have less insulin, that means there's more sugar floating around in your blood. Is it bad? Not necessarily. Growth hormone does something similar. Can it be bad? Absolutely it can, okay? So if you are obese and insulin resistant and on the edge of diabetes, is there a chance this drug is gonna give you type 2 diabetes? There is, actually. I don't hesitate to tell my patients that. We have everybody check, okay? Everybody who starts this medicine should be checking their blood sugars. We have them get a meter. You check once a week for the first 3 months. I just made that 3-month number up. Solano can correct me if they disagree with that. That was just my thinking. Once a week for the first 3 months. And then after that, we get actual labs. We check the hemoglobin A1C and the blood sugars again. And if everything is stable, we check once a month or such after that. I have specific rules. Those of you who are mine know that I send it out like, this is when you're gonna call me and tell me if there's a problem. And so anyway, hyperglycemia, the most common thing that I worry about for my patients. You can see here in these graphs that hemoglobin A1C and fasting glucose, both in the beginning of the trial, do go up a little. I tell people to expect it, but it should stabilize out again over time. Again, if you're on the edge of diabetes, it may kick you into diabetes and you may need anti-diabetic medications. If you're not on the edge, just expect that your blood sugars are going to be a little bit higher when you first start, and they are going to come down with time. It's manageable, obviously. We have a lot of medicines to treat it. And we, like I said, we really do know mostly who's at risk for this, based on, the fact that we've known your kids for forever, and we know, sort of their history and risk factors and whatever for diabetes. So you monitor fasting glucose and hemoglobin A1C when the kids are on the drug. I'm going to tell you one of my favorite stories that Mike Tam probably will shoot me for because he's heard so many times. But one of my favorite stories about this trial was there was an adult, he's 26, and he got diabetes on the drug very, very early on in the course of the trial. And over the course of the 6.5 years of the trial, I've had to add diabetes med after diabetes med after diabetes med to keep his blood sugars under better control. And I say to the mom every single time, if we stop the medicine, then the diabetes will go away because the diabetes is there as a consequence of the medicine. And she says, I will never stop this medicine. His behaviors are so much better on this medicine that I don't care what you throw at him and what you tell me I have to do, I'm gonna do it because I want him to stay on this medicine. And to me, that spoke volumes, because any of you who know me know that my least favorite thing in this world is to medicate the effects of another medication. Hate it. And so that is not my go-to. And so it really spoke volumes to me that she was willing to he's now on like 5 different diabetes meds and she will never stop it. He's good. Other clinical trials we're going to go through briefly. Aardvark, Acadia has carbetocin. They just finished up the carbetocin trial and should be announcing data at some point. I don't know exactly when. If the Acadia people are here, they could tell you. The vagal nerve stimulation test, and then Harmony, the pitolisant for excessive daytime sleepiness. This is a little graph that I made that I really like that shows the mechanism of action of all of these different drugs that are being trialed. And what I like about it is if you look at it, you can see that these different drugs have multiple places that they can act in the brain, and that, and the aardvark people are gonna yell at me because I forgot to put the hindbrain on there. But anyway, regardless, they have multiple places that they act in the brain and multiple different mechanisms of action. I think this is great because this gives us multiple different targets and opportunities for drug treatments for our kids, and I love that. Oh, I did put it on there, nucleus of the solitary tract. All right, aardvark is a small molecule which activates bitter taste receptors. This just got up and running in the past few months in the United States and is, rolling along, and it is gut restricted, so there's no, potential for, well, there shouldn't be a potential for drug-drug interactions. It should be a very safe drug. And it increases the production of satiety hormones from the gut that then go to the brain to hopefully trigger satiety. Their phase 2 results were great. This is why they're doing the phase 3. And so we shall see. I cannot remember. They told us how many they were enrolling, but I've already forgotten. 120, Lauren? Remember? Yeah, something. Okay. Carbetocin, like I said, from Acadia, it's a selective oxytocin receptor analog that hits only the oxytocin receptors. And so it should decrease both homeostatic, which is like we need to eat to live, and reward-driven food intake. So should help theoretically with hyperphagia pretty significantly. And so we shall see. Like I said, the data is, or the study is done at this point. The data, I think they're still, cleaning up and locking up and whatever, but hopefully we'll have another drug at some point in time very soon. Feeding studies in animal models with oxytocin show that, it should increase both energy output and decrease energy expenditure. So in other words, your metabolism should go up while your intake of food goes down, which would be lovely. And so that's that one. Vagal nerve stimulation is the study funded by FPWR. to look at an external vagal nerve stimulation device to control behaviors like outbursts and temper tantrums. In Tony Holland's study that he did before this study started, 4 out of 5 participants experienced a reduction in the number of and severity of their temper tantrums and outbursts. The vagal nerve stimulator is thought to affect neurotransmitters like GABA, which is your sort of, calming down neurotransmitter. And so it's predicted that that's probably why it works. My understanding of this, I'm not doing this trial, but a lot of my patients are in it. It takes a while to work. It's kind of like Vicat, you have to give it a minute. So it's not like an instantaneous fix. You put this on your kid's ear and they're better and they have no temper tantrums. It takes at least 6 months, sometimes longer than that, to really start to have a beneficial effect. But people who have done it swear by it. They think it's fantastic. And then lastly is pitolisant, which is for treatment of excessive daytime sleepiness. It is now FDA approved in the United States for children and adults with narcolepsy and cataplexy. The trial is being done to look specifically at Prader-Willi syndrome. Will this medication help excessive daytime sleepiness in people who have Prader-Willi syndrome? Not necessarily people who have narcolepsy, people who are just fatigued and tired, because that can happen with Prader-Willi, as most of you know. And so that's the trial that's going on, and look, I got it. And so I think that you all need to know, especially those of you with young children and babies, that the future is really bright. It really does. I mean, there's so much hope for your kids to have an improved quality of life. Where'd it go? There. I love this quote. It's one of my favorite quotes in the entire world. Susan, Kansas City Chiefs, up there. I didn't know where you were sitting. I love this. I'm going to read it to you, even though you can read it to yourself, because I just think this is an absolutely spectacular quote. It says, "Don't put people in a box." Any of you have been to see me, what do I say about your children? Don't put them in a box. Why are you telling the world that your child has this disability? You don't know what your child's going to be able to do or not do, and none of us can tell you. It's not fair and it's not okay. The child needs to show us. You never know once you open the box what's going to pop out. So give them a chance. Give them a chance to dream, to achieve their dreams. You never know what they're going to be able to surprise you and be able to do. Are the Sweeneys here still? Anywhere? No? Clara is doing triathlons. She's winning first place in her age group in triathlons. These are not Special Olympics. These are not special needs triathlons. They're just triathlons. And she's doing it with Prader-Willi syndrome. Again, you never know what they're going to be able to do. Don't prejudge them. We have a tendency, though, to do that as humans. We kind of put people in boxes, right? We do it. The world doesn't need more critics. None of our kids need more people to tell them what they can't do. They need people to see their potential. They need you as their parents to, where others see problems, you open those boxes instead of sealing them shut. And you give those who are ready to work the chance to dream bigger than ever before, because our kids deserve it. And that is all. I am done. I will take questions, absolutely. Look, I have 5 minutes. I told you I talk fast. Yes. I don't know. Is there a microphone, Chrissy? Hold on. Thank you.
Just because I'm right here.
Hi, I kind of have 2 questions.
Sure.
The first one is, are there any contraindications with starting sex hormone replacement at the same time as starting Vicat? And then my second one, regarding the hormone replacement, relates to the risk of blood clots.
Okay, so question number 1, any risk of starting hormone replacement at the same time as starting Vicat? Theoretically, no. I never start 2 things at once. If there's going to be a side effect, I want to know which thing caused that side effect, right? If there's a problem, I want to know which it came from. So there's no contraindication to it. There's a Jennifer Miller contraindication to it because I don't like to do that. And you all know that. I never start 2 drugs at once. I just don't. You need to know which thing is doing what. So you give a little bit of time on one medicine and then you start the other. Okay? The risk of blood clots. The risk of blood clots is higher in people with Prader-Willi syndrome. Doing transdermal, so, on the skin, estrogen supplementation tends to be a less risk of blood clots for women. And I don't know about the sub-Q testosterone in terms of how it's going to turn out in terms of risk of blood clots, but it does appear, at least thus far, to be very safe. And I haven't seen any reports of any increased risks of blood clots or anything like that yet. But we've not been doing it very long, probably 3 years. That's not enough time. Okay, so I haven't seen it yet, but I'm not going to say it's not going to happen. People over there. Christine.
Hi.
Oh, yeah, you got it. Okay.
I want to think how many years it's been, but many years back, I was so concerned about dehydration for my daughter. She even had a trip to the ER because she would not drink water. No, I can tell you, we tried every product on the market that didn't have an artificial sweetener in it, and then I finally just decided to stop dying on that hill because she would drink if it had added, artificial sweetener. And now I feel like we're so far down that road because it's been years.
You're not coming back.
And I don't know how to come back. I would love your advice if there is a way to pull back on that. We have the added situation of my child shares households. So this is something we'd have to all be on board with.
Right.
If you have advice, that would be great.
Yes, and again, it doesn't mean that the drug's not going to work, okay, with what your child's drinking. It's just not going to have as maximum of efficacy, at least in my experience. So I would say what I generally recommend, and I don't know if they're here, but I have many, many families in this room that have older children that I have had to make do this, over the years. Mike and I, have done this. And so our recommendation is generally just make sure you don't have anything else in the house that they can drink, because if there's an alternative choice, they're always going to choose the thing that they want. Second, you mess with the water to figure out what works. You try flavored teas, you try really cold, you try sour fruits in the water, you figure out what will work. If nothing else, most kids with Prader-Willi will drink milk. And you can start to dilute the milk with water to make sure that you get enough water into the child so that they're not becoming dehydrated. And that's the way that we do it. And I am a big fan of sending prizes in the mail for people who accomplish this goal. Everybody's nodding because they all know that their kids get prizes when they drink plain water. Because to me, this is a hard goal to accomplish. And I think the kid deserves rewards when they're able to accomplish it, because it is really hard. Everybody has to be on board, though. Everybody has to, as you said, even with different households, everybody has to be on board to do this. And I found the hardest thing is the parents saying, well, but I can't because I want my Diet Coke. I have to have my Diet Coke. And, you're never going to do it. If there's Diet Coke in the house, it's never happening that your kid's going to drink plain water without giving you massive meltdowns every time. And so you just give, And, I have personally found that saying the words like, this is what the doctors told me to do, and I know that it's going to be hard, but we're going to work together as a team to do it. I think that helps. Mike, any others? Oh, I know what you're going to say before
We have
meals.
time for one more question. I think Charles has got them. Sorry.
Wait, Mike was going to say one thing. What were you going to say, Mike?
A lot of times we ask families to build water into a routine. So the best example that we give is, as a family, we're all going to drink 2 ounces of water, and then we get our meal, or 3 ounces of water. Do it as a team, as a family, because that meal is definitely rewarding. Like Dr. Miller was saying, a lot of our kids are very motivated by rewards. But if they know, okay, if I don't get this 2 ounces of water, I'm not going to get dinner.
And you have to stick to it.
Yes, you have to be strict. You can't do broken promises. So if you say something, you have to follow through. But that's something. So I would focus on adding an unsweetened drink, water, milk, unsweetened almond milk or unsweetened milk alternatives. Of course, we would want the sweetened liquids to come down as well, but I would focus on adding unsweetened liquids. But you can use that mealtime water as a team, as a family together. And you can start small. It might just be like half of an ounce of water, and then you get your lunch, or 1 ounce of water, and then you get your dinner. But you have to be very strict, and again, when you say something, you have to mean it.
Yeah, and that's a very good point. I think a lot of times when we say these things, people are like, oh shit, I have to go home and cut out all of the drinks in my life completely because my kid can't have them at all. That's not what we're actually advocating for you to do. Start cutting them down. Do it slowly and then start adding in non-sweetened drinks as well. Sorry, yes.
Hi, Dr. Miller.
Hi.
So you said 30% of boys have been starting puberty regularly on their own.
Mm-hmm.
Do we know how many of those boys had HCG in infancy?
Oh, but that's a very interesting question that I should look at in all my spare time.
Thank you.
I'll get right on that. Is that it?
That's
No
it.
more
We're
questions.
out of
It's
time.
flashing.
It's
All right.
flashing at us. We are good.
All right.
Thank you so much, Dr. Miller. As always, I want to thank all of our sponsors who made this conference possible. Without all of them, we would not be here.